If a baby was born and you noticed the kid had an abnormality, a cleft, maybe a cleft palate, sometimes you're called in to investigate the kid. Is that true?
In fact, it's quite often. There's a percentage, not a large percentage, of babies that have a cleft palate. It's probably somewhere between 5 and 10% of babies born with cleft lip and palate that may have what is called the DiGeorge Syndrome or DiGeorge anomaly, which is essentially, in almost all instances, caused by an abnormality in chromosome 22. And these babies will not only have a cleft in the lip or palate, if they do have the full DiGeorge anomaly, will have a hypoplasia of the thymus, which leads to some immune deficiency. They will have abnormalities in the parathyroid gland that will lead to low calcium, and they'll have certain cardiac anomalies, which we would like to know before they manifest themselves.
So it's like a team approach if you see the kid, because you have to worry about many areas. Is that true?
Right. But I don't want to give the impression that most babies born with a cleft lip or palate have the full-blown constellation. 90% will just have an isolated phenomenon. But it's nice to know early on that a baby may have another problem so one can head off the complications rather than waiting until the baby presents with a severe infection or cardiac failure or potentially low calcium. So it's a good idea right after birth to screen those babies, even though the yield will not be that high, but it's important to do it.
That's why the syndrome concept of trying to look for more than just the problem keeps us from having the problem get out of control. Is that correct?
Exactly right. Exactly right.
So it's not demeaning, it's just trying to help us be better diagnosticians.
Absolutely. Unfortunately, it's just a term that's people hear it, and it'd be nice if we could find another term. Some people are using the term anomaly, though anomaly also has a negative connotation. But exactly right. The word is not demeaning in any way. It helps the providers look for other abnormalities.
Sometimes they don't recognize the kid could have a cardiac abnormality and it may manifest later in life, maybe end of the first year, and the term tetralogy of Fallot.
That's right. When we're specifically talking about congenital defects, most congenital heart defects are not part of what we call syndrome. They're usually isolated anomalies. But certain syndromes, for example, trisomy 21 or Down syndrome, the DiGeorge syndrome or DiGeorge anomaly has specific defects. Tetralogy of Fallot occurs in between 15 and 20%, for example, of infants that have this so-called defect in chromosome 22, which manifests itself as DiGeorge syndrome. 20% will have it.
It's not a high percentage, but it does exist.
As tetralogy, yes, it does exist as 20%, but if you look at all babies that have this DiGeorge anomaly or syndrome, about 80% have significant cardiac defects. Tetralogy being one, truncus arteriosus being another, interrupted aortic arch being the third. So once you decide that a baby may indeed have something like DiGeorge syndrome, the chances are overwhelming you're going to find a cardiac defect. On the other side of the coin, if you have a specific defect like tetralogy, which is very common, if you take all tetralogies, very few will have DiGeorge syndrome. However, it probably makes sense even in those babies to do a simple test to look for DiGeorge syndrome, to be sure you're not dealing with other factors that are presenting themselves as a cardiac problem but may have other problems associated with it.
So genetic counselors come in and they do their different DNA type of testing, is that correct?
That's correct.
Okay.